We've talked about AKI, and now we're going to talk through drug-induced kidney injury. So kidney injury can be caused from a lot of different things, but I think since we're pharmacists, I want to focus on the drug-induced renal injury. You guys can see here in my backyard, just on my deck. It's Sunday evening, and it's possible one of my kitties might come say hi, so we'll see. All right, so drug-induced renal injury. After you've gone through this video, I'm hoping you can go back and when you hear a type of injury, think to yourself what drug might have caused that. We have 3 types of acute renal injury. We have pre-renal, intrinsic, and post-renal. Those are not necessarily mutually exclusive. So if you have one type of injury, it might cause another type. And then I did want to talk about some chronic causes of renal injury. We're only going to talk about a couple examples though. So anything that is in bold will be a drug to know for your exam. And then, let's see, overall, I'm also hopeful you can provide some prevention strategies and make recommendations to decrease further drug-induced renal injury. All right, so this is true for everybody, no matter what drug they're on. If they're older, if they have multiple nephrotoxic drugs, or if they have pre-existing renal disease, so if they already have CKD, they're at a higher risk for acute kidney injury. Also, for prevention and management of drug-induced acute kidney injury, if we can minimize the use of nephrotoxic drugs, that will hopefully prevent the injury. We use them when the benefits outweigh the risks, which is really common in the hospital. We can fry the kidney and then let it recover later. So it's not always that we don't use nephrotoxic drugs, but we try to limit the use of them. And then we try to make sure we maintain hemodynamic stability. Basically, we need to make sure that our patient is really well hydrated. Okay. So first I'm going to talk about pre-renal AKI. These are things that alter the blood supply to the nephron. So I mentioned at the very beginning of block, something that's going to alter supply to the nephron is going to be your worst kind of injury. So if we don't get enough blood to the nephron, now we're going to have injury further on. So if we don't have enough blood supply, we're not going to get the nutrients and the oxygen that we need, and you can have cells dying off. So you could potentially have pre-renal injury that causes cellular death further on. Okay, our triple whammy. So we're going to have an article for you to read about the triple whammy. But the key point here is that our NSAIDs can cause renal injury, our diuretics, and our ACEs and ARBs. They all cause pre-renal injury, but they all do it in a different way. So NSAIDs, I've got a picture on the next slide, but it's related to inhibition of prostaglandin synthesis. And so the afferent arteriole wants to vasodilate, it wants to get bigger, but it can't. So it keeps it from getting as big as it wants to be. People who are at most risk with NSAIDs are patients with CKD, our elderly patients, people with blood supply that's not ideal. So like somebody who has CHF or cirrhosis, so they do have a lot of fluid, but it's not really in the ideal places. Or again, taking multiple NSAIDs. Diuretics. So these basically just cause more renal injury because your patient is, they have lower fluid, more dehydrated basically. And older adults are the ones who are going to be at higher risk of this. And then ACEs and ARBs. So ACEs and ARBs don't cause renal injury by themselves. It's only if there's already a problem going on. So if you already have some pre-renal injury, your ACEs and ARBs are going to make it worse. The kidney might want to be able to vasoconstrict the efferent so it can control GFR. If you constrict the efferent, you're going to push more blood into the filtrate, or you're going to increase pressure. Maybe the kidney doesn't have enough pressure to push stuff through. So if it can't regulate that because of some other pre-existing problem, your ACE and your ARB is going to make it worse. And so people who are at risk for injury from ACEs and ARBs, it's going to be those who are already taking something in our triple whammy. So NSAIDs or diuretics, or potentially elderly patients again, or somebody who just started an ACE or an ARB. All right, so here's a little visual representation of this. Let's see, where can I put myself? Okay, here's the triple whammy. We've got our afferent on the left, and then glomerulus, and then efferent arteriole. All right. If you have an NSAID come in, it's going to decrease prostaglandin synthesis and not allow your afferent to vasodilate. So your afferent is smaller than your kidney wants to be. You don't have enough blood coming in. That's what this is. If you have a loop diuretic, you're going to increase the amount of blood that goes through into the filtrate. And remember that the blood coming in here, if it goes to the filtrate, it's not going to supply blood to the kidney itself. Only the blood going through here is going to be used by the kidney to give its own blood supply. Then if you have an ACE or an ARB, it doesn't allow your efferent to vasoconstrict. So it's keeping this wide open. So if you have an NSAID that's keeping this shut, and you have a loop that's not giving you very much fluid, and you can't make this any smaller because your ACE and your ARB isn't letting you, then you are not getting a good supply. Pre-renal AKI, the biggest players here are ACEs, ARBs, NSAIDs, and diuretics, and there's some other medications that act kind of like them. Take a look at our primary literature article, not necessarily for tomorrow, but maybe in your free time on PP3 day or in the evening for PP3 day, and we'll talk about it more on Wednesday and Thursday. Radio contrast media. So this is something that we use to take an image, like in an MRI. You might want to give them some media that'll make their cells highlight on the MRI. So the media itself can cause afferent arterial vasoconstriction, which will look really similar to if they were taking NSAIDs. So there's a bunch of different diuretics, and so it's not necessarily like all diuretics cause the same kind of injury because it depends on their mechanism of action. So loop diuretics and metolazone, which is a thiazide diuretic, they're primarily used for disease states where you need fluid removal. So if you have a disease state where you need fluid removal, you're already at increased risk for AKI. So having these agents should put you on high alert to look for AKI. So here you can see a list of them. We've got our loops, thiazides, metolazone are there, aldosterone antagonists or potassium sparing. I don't really think of aldosterone antagonists or potassium sparing diuretics as causing AKI. They definitely can make AKI more dangerous, like if they have hyperkalemia. And maybe that's going to push them over the edge to needing treatment for hyperkalemia. But the actual fluid changes are going to be most prevalent with your loops and thiazides. The only reason I didn't bold metolazone and indapamide is because I don't see them as often. So definitely know about it for chlorthalidone and HCTZ. All right, lithium. So lithium, as you remember from your neuropsych 1 block, lithium can be pretty tough on the kidney. We're going to talk about its acute kidney injury and also it can cause chronic kidney injury. So lithium can cause nephrogenic diabetes insipidus. I have another document about this as well, I'll post for you guys. Nephrogenic means of the kidney, from the kidney. Diabetes insipidus means high sodium. So as opposed to diabetes mellitus, where it's high glucose, this is going to be high sodium. And the issue here in diabetes insipidus is antidiuretic hormone isn't able to do its job. So lithium will actually alter the kidney's ability to respond to antidiuretic hormone. The area of the nephron that antidiuretic hormone works on is mostly the collecting duct, and the fluid in the collecting duct is going to be really low in sodium. So you keep losing a bunch of this really low concentrated fluid because ADH isn't working to close the aquaporins. And you just keep losing this low sodium fluid, and so the stuff that's left over is really high sodium fluid. People a lot of times will look almost euvolemic because in addition to polyuria from your ADH not working well, you also have polydipsia, so they're drinking a lot of water. So when you go back to Dr. Lowe's material, this is what is called euvolemic hypernatremia. It's from diabetes insipidus. This is actually life-threatening. So if you're say you're working in community pharmacy and you have a patient who is on lithium and they say they just can't stop peeing or they just are really, really thirsty, send them to the emergency department. As you learned with Dr. Lowe, large changes in sodium concentration can be really, really painful for your brain. It can potentially cause severe brain damage if it changes too fast. And so they need to go to the emergency department to get taken care of. The thing that you'll primarily pick up in labs is a very high sodium. Okay, so the reason this is pre-renal injury, even though it's happening in the collecting duct, it ends up being pre-renal injury because they're going through so much fluid. So you're altering the amount of fluid that's available to the kidney to be blood supply. And so ultimately you're causing pre-renal injury. So the kidney is not getting enough blood to itself. Okay. Intrinsic drug-induced injury. So this means injury to the cells itself. A lot of these drugs are drugs that we give in the hospital. So acute tubular necrosis, just like it sounds with necrosis, it's cells actually dying, and it's in particular tubules. Normally you give a drug, but then when you stop it, the kidney's going to recover. A worst case scenario would be you give a drug, you have some cells die off, those cells begin to slough up, and they might obstruct the tubules, but then you stop the drug, and the kidney recovers. What we really want to prevent is this. You give the drug, cells die off, they start sloughing, you cause tubular obstruction, the drug hasn't been stopped because we haven't recognized it, you have a buildup of waste products, you have more cell death and more renal injury. So overall, we're trying to stop this process. When we figure out we have some tubular necrosis going on, we want to address it, stop the process, and let the kidney clear those dead cells. So that's going to be a major goal of therapy, is to prevent this scenario, because really severe acute tubular necrosis could lead to end-stage renal disease. So if we can, we'd like to simply remove the drug. But if we need to continue the drug and know that we're going to cause some tubular necrosis, we can hopefully provide supportive measures to prevent acute tubular necrosis to progressing to this stage. So if you think back, what were our universal strategies to reduce the risk of AKI? So each of these drugs coming up all cause acute tubular necrosis, but they all do it in a little different way. Each drug has a different probability of causing our worst case scenario of acute tubular necrosis. So it's going to depend on the drug properties and also the comorbidities of the person who needs the drug. For each of them, we'll talk about how it gets to the tubules in the first place, and then strategies to reduce worst case scenario. So aminoglycosides. These are antibiotics. They're generally reserved for severe infections, and they're very, very highly renally eliminated, and they're also quite nephrotoxic. Part of the reason why we know they're probably going to fry the kidneys is because we have to give a pretty high concentration in order to kill the bacteria. So these are what we call concentration-dependent antibiotics. So here's the process of how it gets there. So our aminoglycosides are freely filtered through the glomerulus. Just like serum creatinine, there's nothing we can do to prevent it from getting into the nephron. So after it's freely filtered, it will actually concentrate in your proximal tubules and bind to those cells. And after it binds, it's going to interfere with function and kill them. So it is directly nephrotoxic. There is nothing we can do to prevent. If we give an aminoglycoside, we know we're going to cause some cell death. So what we do to reduce injury, we've changed, most of the time now we're able to give it as one large dose, so that we go in there, we fry the bacteria, we fry the kidney, and then we give the kidney a break. Luckily, the drug has a post-antibiotic effect, is what we call it, where it continues to kill off bacteria. So if we let the kidney kind of recover, clear out those dead cells, give lots of fluid to help get rid of those dead cells, then we can get the kidney ready for tomorrow's dose. So give a big dose, give it a break, let the kidney recover, flush out all those dead cells, and do it again. So a lot of times pharmacists are asked to provide monitoring and dosing for aminoglycosides. So we will practice this a little bit in the spring in the ID blocks and in Pharmacy Practice 4. The big things we do to monitor is we do monitor daily serum creatinine for patients with aminoglycosides, because if they get too bad of AKI, like if it gets really, really bad, we may need to use something else. We also want to get rid of any other nephrotoxic agents. So if we're using aminoglycosides, it means that our patient is really sick. So it's not time to be giving them ACEs and ARBs or NSAIDs. We need to focus on just knocking out this infection. We also can do what we call a trough measurement, where we look to make sure it's adequately eliminated. So when you see a gold trough for aminoglycosides, it won't say approximately 0, but that's really what your goal is, as low as possible. So that's the nice thing about giving that once daily aminoglycoside, is the kidney should be able to eliminate all of it and then have a break. We used to historically give aminoglycosides 3 times a day. And so you'd still want a low trough, but you wouldn't have as long in between doses and then therefore kidney injury. So these are safety monitoring parameters. We also better make sure we're using the right drug. So a big thing, you'll see a lot of the drugs that cause tubular injury are antibiotics. And that's because antibiotics are made to kill something that lives, and our kidney is something that lives. And so it's hard to only target bacteria. You're going to get some effects to your body as well. So one of the big things we need to make sure we're doing is making sure that our culture says that we're using the right drug. And we need to make sure we're looking at the patient status to ensure treatment is still warranted. Aminoglycosides are a lot of times used for urinary tract infections. And so we definitely have to make sure we're checking a culture each time and that our patient's actually sick enough that they need it. All right, radiocontrast media. So I already mentioned this in the setting of pre-renal drug injury. Again, it's that IV dye. So it also, in addition to pre-renal, it causes intrinsic as well. So radiocontrast media disrupts prostaglandin synthesis, similar to your NSAIDs. And then it causes vasoconstriction, similar to NSAIDs. You have reduced renal blood flow for several hours, again, similar to NSAIDs. The new thing here that we haven't talked about yet is the concentration will build up in renal tubules. So when you have low blood flow, you're going to have even more of a buildup of this concentration. And radiocontrast media is also directly nephrotoxic. So it also causes injury just from being concentrated in the tubules. So it can cause extra cell death from there. Okay? So you can have pre-renal injury. This is all pre-renal. But because this pre-renal injury is there, it's actually making it worse. It's making it more concentrated in the tubules and causing cell death. The extent of injury is directly related to the duration of tubular cell exposure. So if we can get this cleared out faster, you'll have less injury. And that's where we get our strategies. So if we give isotonic saline before and after we give radiocontrast media, we're getting more fluids just sitting right in the vasculature, and therefore it's going to decrease the concentration of radiocontrast media. And also, by giving more fluid, you're going to decrease vasoconstriction because you have extra fluid there, it can't constrict as much. So you're getting two things. You're decreasing the pre-renal injury, and you're also decreasing the intrinsic injury. Another strategy is we try to minimize the amount of radiocontrast media that we use. There are different types of media, and we use low or isoosmolar contrast agents to do less injury. All right, amphotericin B. This one sometimes gets the nickname of amphoterrible because it's very nephrotoxic. So it's an intravenous antifungal agent that's used for severe fungal infections. So amphotericin B causes a lot of stuff, as you're about to see. So it does cause intrinsic injury. It gets inserted into the tubular cell membrane, and then it creates pores in the membrane. So it's actually punching holes in the cellular membrane. Since there's holes punched, you're increasing cellular permeability, and your cells are spilling the stuff they need, so they die off. So here's the cell that's open, and it's wasting electrolytes like potassium, bicarb, and sodium. So that electrolyte wasting, you actually have to also monitor all those electrolytes if they're getting amphotericin B. And then notice that bicarb is wasted. So you can have a local acid-base disturbance. So if you picture like pouring kind of acid on your kidney cells, you can have extra nephrotoxicity just from this component. So you're not only killing cells by making stuff leak out, but by leaking out bicarb, you can potentially kill off more cells. We're not done yet with amphotericin B. So amphotericin B also causes vasoconstriction of the afferent arteriole. So same as NSAIDs, same as radiocontrast media. That's again, it's going to limit the perfusion of the kidney. They think the way it does that is it goes into the macular densa cells, which is one of our early cells for sensing sodium and figuring out what it should do with the RAS. And so if it's changing the way the body is responding to sodium, it's going to actually activate RAS more and cause more vasoconstriction. So strategies to reduce injury of amphotericin B. We can pre-treat with isotonic saline, again, to fight that vasoconstriction, give more fluids so that our afferent arteriole will stay open. There's different formulations of amphotericin B. So we have a liposomal formulation, which reduces the incidence of kidney injury, but it's still 15%, so it's still pretty common. Again, limit the use of other nephrotoxic agents. And now we have some newer antifungal agents, so you might be able to switch to one of them. All right, whole new kind of mechanism. This is still intrinsic injury, but it's acute or allergic interstitial nephritis. So this is a severe inflammation and edema of the renal interstitium. It's usually seen about 2 weeks after you started a drug, unless they've previously been sensitized. So I mean, like, unless they've had the drug before, then it might start faster. So you give a drug, and it causes some sort of immunologic response within your nephron. The interstitium becomes inflamed and edematous, and hopefully when you stop the drug, the kidney will recover. If you didn't stop the drug, it can cause continued injury, which can result in fibrosis and tubular dysfunction. So there's a lot of antibiotics that can cause this. Sulfamethoxazole, which is generally prescribed as Bactrim, which is sulfamethoxazole combined with trimethoprim. Fluoroquinolones, ciprofloxacin is especially associated with this, but it could happen with any of them. It's generally used for more severe urinary tract infections, but a lot of people use it inappropriately as a first-line agent for urinary tract infections. Penicillins and cephalosporins. So really any of them could cause this, but it's much more common with more of our inpatient setting of penicillins and cephalosporins, like Zosyn, which is piperacillin, and tazobactam. I think another reason why you'll see it in inpatient settings more is because a lot of our infectious organisms can also cause acute interstitial nephritis. So let's say you have a bacteria and your kidney is responding to that with an allergic response. You're going to have that plus potentially your antibiotic adding insult to injury. So our big way to reduce this is using good antimicrobial stewardship. Again, making sure they're only on the antibiotic for as long as they need to, no excess antibiotics. Since multiple antibiotics can cause it, using multiple agents as opposed to just one is going to increase your risk as well. We only want to prescribe an antibiotic if we're pretty sure it's because of a bacterial infection. We don't want to give it if we think it might be viral. We want to limit the use of multiple antimicrobial agents again, and this is an activity where pharmacists are becoming more and more involved. Sometimes they're doing this in emergency departments as well. We do try to limit giving NSAIDs plus antimicrobials because NSAIDs can also cause acute allergic interstitial nephritis. So it's kind of its own double whammy, NSAIDs plus antibiotics. And if you think about it, NSAIDs are used pretty commonly for things like headache, which are pretty common with fever. So it's something to keep in mind. It might be a reason to limit the use of NSAIDs for somebody who's on antibiotic. Again, maintain adequate hydration during treatment. That way, if they do get some inflamed interstitium, they've got some extra fluid going through to help them out. There are a ton of medications that can cause this. So I went over some of the big ones like antibiotics and NSAIDs. There's multiple diuretics, multiple neuropsych drugs, so many drugs. So basically, if you see somebody that you think they're having acute or allergic interstitial nephritis, get a med history and perform a drug information literature review. Again, keep in mind it's usually presenting about 2 weeks after they first start the drug. All right. Local acid-base changes. So if there's a drug that alters bicarb exchange in the nephron, that's going to cause a local acid-base disturbance. So those cells right there are going to die off. Hopefully, though, you stop the drug and the kidney recovers. But if you don't stop the drug, those cells that are dying off, again, they can slough off and now cause a post-renal obstruction. So I talked about amphotericin B already. Another one to bring up is topiramate. So if you remember topiramate from our neuropsych 2 block, we use it for migraine prophylaxis. We use it for a couple different things. So topiramate has a property called carbonic anhydrase inhibition. So there's another drug called acetazolamide that we use just for this purpose. So we'll actually give people acetazolamide to prevent or to treat altitude sickness. So basically, if we're giving acetazolamide, we're trying to inhibit the elimination of bicarbonate to urine. So we're actually causing a metabolic acidosis. The problem is topiramate, we're not using it for that purpose, right? We are using it for migraine prophylaxis. So this, for topiramate, it's an unwanted side effect. It's a weak carbonic anhydrase inhibitor, so it shouldn't be as marked of a response as it would be with acetazolamide, but it can cause a bicarb problem. So that's why you might remember that we monitor bicarb for people who are on topiramate. The risk of metabolic acidosis is higher for people with CKD who have been started on topiramate. So if you think about it, CKD also, you have a risk for metabolic acidosis. So it makes sense that if this is going to make the situation worse, it's going to be more likely to happen in somebody like that. All right, we got one more drug that can cause intrinsic injury, and we don't really know why. So vancomycin is another renally eliminated antibiotic. We use it for severe MRSA infections. This is what we call a concentration-dependent antibiotic, meaning we have to keep it at the right, sorry, I said concentration-dependent, I meant time-dependent. We do have to keep it on the right concentration, but it has to be at that concentration for a long time. So vancomycin is what we call a time-dependent antibiotic. This is basically because vancomycin does not kill bacteria. It just inhibits the growth of bacteria. So it's got to be present for a long time to really make a difference and let the body then fight the bacteria. We know that it seems like vancomycin, based on the types of injuries it's causing something wrong with the proximal tubules, but we don't really know what it is. We do know that there were older formulations of vancomycin that were more likely to cause renal injury. We refer to them as Mississippi mud. And now that we have better manufacturing practices, we have less of it, but we still definitely have nephrotoxicity from vancomycin. Another reason why we don't really know why it causes injury is because patients who are getting vancomycin, they usually have a lot of things going on. If somebody is septic, that means their infection is really bad and their fluids and electrolytes are not regulated normally. So somebody with sepsis is going to have pre-renal injury because they're not hemodynamically stable. A lot of times too, if they're getting vancomycin, they're getting lots of other IV antibiotics at the same time. So they might be getting multiple nephrotoxic agents. We do know that vancomycin nephrotoxicity, if we give higher doses and higher concentrations, we're more likely to have nephrotoxicity. So what we do to prevent this, pharmacists are really, really commonly consulted to dose, monitor, start, all the stuff for vancomycin. So we'll practice this a lot, actually, in pharmacy practice. Same as with aminoglycosides, we monitor serum creatinine daily. We reduce other nephrotoxic agents. We have a goal trough. So as opposed to aminoglycosides where our goal trough is as close to 0 as possible, for vancomycin, we need to maintain a trough because it's time dependent. It has to be at this concentration for enough time. So our goal is usually around 10 to 20. We want to be right at our trough. We don't want to be below it because then it won't work, but we don't want to be too far above it because that increases our risk of nephrotoxicity. I mentioned before that vancomycin can be used to kind of tell if somebody's having acute kidney injury. So my example is a lady who was in the ICU. She had multi-organ failure, but her serum creatinine looked really low. The reason her serum creatinine looked low is because her liver wasn't working, so she wasn't creating creatinine, but she also wasn't eliminating it because her kidneys didn't work. So I gave her vancomycin, and we would get what's called a random level. It's not a true trough because her kidney's not working, but we get a random level, and when I got it again the next day, it was the same. So that showed that her kidney wasn't able to eliminate any vancomycin, really. So you couldn't tell that she had AKI just from her serum creatinine, but you could definitely tell it when you were monitoring her vancomycin. When you're looking for efficacy, you have to make sure that the culture is appropriate for vancomycin. So vancomycin should only be used for gram-positive bacteria. So if it's gram-negative or if it's susceptible to methicillin, then you should be using a different antibiotic. And then again, we're going to make sure the patient is sick enough that they need vancomycin. Okay, so we talked about pre-renal, we talked about intrinsic, now we're going to talk about post-renal. A lot of our intrinsic meds, if you have cells dying off and they start blocking flow, they can cause post-renal from that. So some drugs can actually crystallize in the tubules. So acyclovir, ciprofloxacin, methotrexate, sulfamethoxazole, and triamterene can all precipitate as crystals in the tubules. So that if there's crystallization, it can block up all the flow because you've caused an obstruction. It can also potentially cause interstitial nephritis, which makes sense since we saw cipro and sulfamethoxazole on that last list. And if you have enough blockage, you can also cause necrosis of the tubules as well. Nephrolithiasis, that's the big word for kidney stones. So there are some medications that are more prone to causing kidney stones. A lot of times people, if they have kidney stones, it's because they have calcium deposits in the kidney. So stones can be caused from a few different things like uric acid and stuff like that. But if their stones are caused by calcium, taking more calcium is going to make that worse. People who take really high doses of vitamin C, like that emergent C, things like that, that vitamin C is acidic. So it can lower the pH of the urine. And if there are drugs that are more likely to crystallize in a lower pH, and if you think about it, topiramate and amphotericin B potentially could also do that. So they also make it more acidic in that area. So these vitamin C or topiramate or amphotericin B, they could all cause something else to crystallize and precipitate out and cause blockage. Anticholinergic drugs. So a classic one is oxybutynin. These block the actions of acetylcholine, which causes urinary retention. If you're retaining urine, it's not going out as quickly as it needs to, and so that's considered a post-renal obstruction. And then just FYI, I think we talked about this enough in other classes, but oxybutynin is used for overactive bladder. Okay, that was all of our acute drug injury. We're going to talk about just a little bit of chronic drug injury. So lithium, cyclosporin, and tacrolimus can all cause acute drug injury as well. Lithium, we already talked about, it causes diabetes insipidus. Cyclosporin and tacrolimus, they cause a similar vasoconstriction to NSAIDs. Unfortunately, all these drugs can also cause chronic renal injury. And the way they do so is the same. It's called chronic interstitial nephritis. It's, again, chronic. So the longer you give it, the more likely it is to have. It can progress. And unfortunately, it's usually irreversible. So for lithium, they think it might actually be the same thing that happened in diabetes insipidus. It's just a chronic presentation of it. So diabetes insipidus symptomatically is very noticeable, whereas if it's this chronic interstitial nephritis, it may not be noticeable to the patient. It kind of develops slowly, insidiously, during several years of therapy. In fact, it's usually, if somebody's going to get chronic kidney disease because of taking lithium, it usually occurs after 10 to 20 years of therapy. So lithium is a great drug. It really works well for bipolar, but unfortunately, it's very nephrotoxic. So the way that you might detect this is an increase in serum creatinine or BUN, or potentially somebody having new onset of high blood pressure. You might also, the start of this might be somebody who has diabetes insipidus, and then once they've recovered, they may have chronic interstitial nephritis from lithium. So basically what we do to try to reduce this is use as low of lithium concentrations as therapeutically possible. So enough that their disease state is controlled, but no more than what they need. Also, if people are on lithium, they should avoid dehydration. And one of the most dehydrating things is alcohol, because alcohol also blocks the effects of antidiuretic hormone. So it makes you urinate a lot. And then we monitor renal function really closely for people on lithium. Cyclosporin and tacrolimus. You'll talk about these in the immunology block. These are basically mainstays for renal transplant therapy. So something that we use to prevent rejection of a renal transplant, unfortunately, also causes a lot of renal injury. So the type of injury here is generally delayed interstitial nephritis after several months of therapy. So if you remember, acute interstitial nephritis is after about 2 weeks. This doesn't happen until several months, usually. The toxicity is usually progressive, but it's not entirely dose dependent. You'll see this as a slow increase in serum creatinine. Our strategy to reduce renal injury: use the lowest effective dose, even though it's not totally connected to dose. Discontinue these meds if there's renal dysfunction, but we don't really know how effective these strategies are. So what's the right answer? I don't know. But basically, yeah, cyclosporin and tacrolimus can cause chronic interstitial nephritis. Think to yourself, which drugs from this presentation had multiple mechanisms of injury? A lot of them did. This presentation is definitely not all-inclusive. I just tried to come up with some of the big ones. A lot of drugs can cause injuries in multiple ways. Remember back to our NSAIDs, they can cause pre-renal injury, they can cause acute allergic interstitial nephritis. If somebody has more comorbidities, they're more likely to have multiple drugs that can cause renal injury in either similar or synergistic mechanisms. So a patient like that is going to be your highest risk of drug-induced renal injury. And that is the end. We will, I just wanted to give this to you so you could see it, look at it, start putting some of that stuff in your brain about how each med causes injury and what we can do to prevent it. In class later this week, let me pull up the syllabus. Okay. On our syllabus, today is just to get through these couple lectures. On Wednesday, we're going to actually play what I call dodgeball. So when we play dodgeball, I'm going to ask for 16 volunteers. And I have a ball with me. I have a trumpet as well. I'll probably play the national anthem, even though I haven't practiced my trumpet in over a year. So it'll be bad. But we will give one person the ball, tell them the name of a drug, and they have to throw the ball at the appropriate area if the drug causes pre-renal, intrinsic, or post-renal. So we'll do that to help you review this a little bit. And then the other article as well, but the article is the triple whammy article. If there's anything that we didn't get to enough on Wednesday to review this material, we also have Thursday morning as well. So this is out there for you so you can start studying it, and then we'll start applying it on Wednesday and Thursday. All right, thank you.